first section, then, we'll describe our journey for the discovery of Keratin 17 as a prognostic and predictive biomarker. So the problem that I addressed here represented a paradigm shift from the type of research that I did when I was on the faculty in the Department of Pathology at Colorado, because at that phase, up to that phase of my career, I'd always been interested in the discovery and validation of diagnostic biomarkers with the rationale that my scope as a pathologist was limited to diagnosis, but that by integration of molecular biomarker testing, I could enhance diagnostic accuracy. And I saw that as my limit or objective as a 20th century perspective on the practice of pathology. Out of that work came the discovery of P16 as a biomarker of high-grade dysplasia and cervical cancer. And I was very gratified that we were able to establish that for the first time at Colorado and to deploy it for diagnostic testing in our histopathology laboratory. And we were the first site in the world to start to use P16 for evaluation of histologically challenging cervical biopsies. So that was completed shortly before I moved to Stony Brook. And when I got to Stony Brook, then I had access to some resources and a lab, but also some time to reconsider what to do next. And the first thing I thought about was, well, I could look for another diagnostic biomarker of cervical cancer, but that wasn't very interesting because P16 worked great. And I didn't perceive that there's a need to improve on that. But then I thought, well, is it possible that all these years I've had the blinders on, that I really have had a 20th century perspective, that I can only think about diagnosis? Maybe I can go beyond that. And specifically, if I imagine two different patients that both had a diagnosis of cancer, let's assume that the cancer is of the same anatomic site and the same grade and the same stage, then very likely they'll both be treated the same way, but one might live while the other dies. And this suggests that there were fundamental differences in these tumors between the two different patients that I was failing to address by simply establishing the diagnosis. So therefore, I decided to advance my work to move from a focus on diagnostic biomarkers to try to find prognostic biomarkers that might tell me what was actually going to happen to the patient. And the ulterior motive for doing that was that if I could find such a biomarker, it potentially might even serve as a predictive biomarker to guide more effective treatment, or even potentially highlight new avenues for therapeutic intervention. So my laboratory is focused on trying to understand differences in molecular biology between cancers, with the ultimate goal of trying to develop better ways to treat and cure cancer. So since I had started the work in the pathway working on P16 in cervical cancer as a model system, I stuck with cervical cancer initially for a prognostic biomarker discovery effort. But in this case, taking access to some laboratory resources that I had in the department here at Stony Brook, I used laser capture microdissection to cut out epithelial cells from cervical mucosa at different stages of progression of cervical dysplasia up through invasive squamous cell carcinoma, and then extracted the protein, took the protein aliquots to our mass spec core lab. And basically the gist of the conversation was, I don't know how mass spec works exactly. I just want you to take these tubes and tell me what proteins go up most significantly in correlation with disease progression. So a couple of weeks later, I got a list of a couple of thousand proteins, and I looked at the top of the list, and there was a keratin. I thought, well, I hadn't paid enough attention to all the work that Bob Evans had done at Colorado when I was a graduate student, which I regret very much now. But I thought keratin's structural protein, that's probably not going to be it, probably just a contaminant. So then I looked at about the next 20 proteins on the list, and there were things that I already knew about, and they included P16 in proteins that I knew regulated cell cycle progression, like topoisomerase 2 alpha and ECMs and various other proteins that I did not expect were likely to drive disease progression. So I decided to go back and look at that list again to see what was at the top. And at the very top of the list was a keratin, as I mentioned, but it was one that I didn't specifically know anything about at that point, namely Keratin 17. And as I looked at the list, I saw that it seemed quite extraordinary that it went up 350-fold in cervical cancer compared to normal mucosa. And then I decided to take a look at the bottom of the list, and I found other keratins that showed a reciprocal relationship. For example, Keratin 4, which dropped 250-fold from cancer, from normal to cancer. So as I thought about that, I thought, if it's a contaminant, how come one keratin is going up and another keratin is going down? And decided, therefore, to get access to a Keratin 17 antibody to see what it looked like by immunohistochemistry to see if there really might be something there. And as I did that, we started out looking at a handful of cases of cervical mucosal biopsies. And my comment, as I looked at the very first slide, which was an HSIL case, was pretty cool. It looks just like P16. But then I thought, well, who cares? P16 is great. I don't need another P16. But then I looked at the next slide, also HSIL, and it was completely negative. I thought, that's quite strange, because if this were P16, it would be positive in every single case. So then I looked at a large number of cases, 74, with an up-and-coming, very bright graduate student in my lab, who's Luisa Escobar Hoyos. And as we went through these cases, we found that about a third of the cases were Keratin 17 positive and 2/3 were negative. So I asked Luisa to go back and figure out what does Keratin 17 expression status correlate with. And she came back several days later. And she looked disappointed and said, well, it doesn't seem to correlate with anything. It doesn't correlate with the grade or the stage or the histologic subtype or the HPV type. The only thing it correlates with is how long the patients live. So I thought, well, that's actually really interesting. Let's look at that. So we looked at a large number of cases and again found that about a third were Keratin 17 positive, 2/3 were negative. And looking at the correlation with survival, we found that there were big survival differences between the groups that I could not have predicted by histologic assessment of the tumor specimens or by any clinical indicator. The stratification was through multivariate analysis, independent of any other factor. So I thought, great, we need to write a paper real quick. Nobody's seen anything this good before. But wait, before we write the paper, even though we know it won't work, the reviewers are going to want to know that we have a complete study. So we need to get some advanced stage cancers and test them too. But we know that for advanced stage cancer, it's not likely that a biomarker is going to impact survival. So I was wrong. And when Luisa came back several days later, she said, well, if they are stage 3 or stage 4, but they don't express Keratin 17, the 5-year survival is around 90%. But if they do express Keratin 17, they almost all died with a hazard ratio of over 8-fold. So this was really extraordinary. And we then prepared to write the paper. At the same time, we started to think of a lot of really interesting questions, one of which was, could it be conceivable that Keratin 17 was not just a biomarker of the most aggressive forms of cervical cancer, but could Keratin 17 and intermediate filament be driving tumor aggression? So to address that, We started to think about what could we do in an experimental model system. So I, as a graduate student, learned that keratins are intermediate filament proteins that normally have a distribution that reflects the distribution of the cytoskeleton in non-dividing cells. When I started to read about keratin 17, I learned that it was normally expressed in the embryonic ectoderm, but is silenced in adult somatic tissues, except in certain specialized stem cells. But that there was some evidence that in certain types of cancer, at least, it could be sporadically re-expressed. So moving from that, we decided to start to look at keratin 17 in cells grown in culture. And the critically important step that was taken here was to see if there's a change in the distribution of keratin 17 that depended upon whether or not the cells were serum starved or senescent versus those that were stimulated to divide. So when Louisa first started to look by super resolution microscopy at keratin 17 in 2 different cervical cancer cell lines, she found that if the cells were not dividing, there was a pattern of staining that looked just like what we saw in the previous slide, where there is a filamentous network in the cytoplasm. But when she gave these cells fetal bovine serum, she started to see speckles instead, and these speckles were in both the cytoplasm and in the nucleus. And her first reaction, very understandably, was something's got to be wrong, because keratins should be making speckles, and keratins, so far as we were aware at that point, don't go in the nucleus. Therefore, it's got to be an artifact. So Louisa worked very hard to try to figure out how to wash out the speckles. And after about a week, she gave up. She thought, they're not going away. Is it possible that this is real? So the first question was, has anyone ever described a keratin that goes into the nucleus? And the answer to that was no. And then we asked, well, how do other proteins get into the nucleus? And the answer to that was through nuclear localization sequences. And before I get to that point, another question is, why do the speckles only occur when the cell starts to divide? Could there be any relationship with a regulator of cell cycle progression? So we decided to look at P27, a master regulator of G1S progression. And by immunoprecipitation, we saw subtle differences in P27 after treatment with fetal bovine serum in both CHA and Kasky cells. But with nuclear fractionation, we saw that keratin 17 was immunoprecipitating the nuclear fraction of P27. And that furthermore, the level of nuclear P27 seemed to be diminished 3 hours after stimulation with fetal bovine serum. So to the center panel then, Louisa used 2-color IF and was able to show by co-localization some evidence that there might actually be a physical interaction between keratin 17 and nuclear P27. So back to the question of how could a keratin get into the nucleus? Louisa started to read about nuclear localization sequences and other proteins to understand how other proteins get into the nucleus. And then she looked at the amino acid sequences of all 54 keratins that have been described to ask if any of those encoded a nuclear localization sequence. And she found, very interestingly, that keratin 17 is the only keratin that encodes a conserved classic bipartite nuclear localization signal. So this suggested that, in fact, keratin 17 could go into the nucleus. So the question then was, if it could go in, could it come back out? Therefore, she read about nuclear export sequences and surveyed all existing keratins and found that keratin 17 also encodes a leucine-rich nuclear export sequence. So knowing then that Keratin-17 has the tools that it needs to traffic in and out of the nucleus, we started to look more carefully at what the functional domains are, and to further try to understand specifically how could Keratin-17 bind to P27 or potentially other targets within the nucleus. So through this, by analogy with other proteins known to bind to P27, we identified two separate protein targeting domains, which predict interaction not only with P27, but with some other protein targets that share amino acid similarity. In addition, we identified a chromatin remodeling domain, which is proving to be interesting, and I'll talk a little bit more about that later. This cartoon summarizes part of what we know at this stage about what the general concepts of some of the properties through which Keratin-17 may impact cell cycle progression. We now know that in response to a mitogenic signal, post-translational modifications can allow Keratin-17 to detach from the cytoskeleton and to solubilize, and that the soluble form is able to bind to important, and the complex is able to move into the nucleus, enabling Keratin-17 to bind specifically to P27. In addition, there are other predicted protein targets of nuclear Keratin-17. Once bound to P27, Keratin-17 through its NES interacts with exportin to mediate nuclear export of P27 and degradation, supporting sustained cell cycle progression, which would be predicted to make the tumor grow faster. And we thought, that's great. Gives us some insight as to why these tumors are more aggressive. But then at the same time, I was a little bit skeptical as a pathologist, because if it was simply a matter of regulation of cell cycle progression, that ought to mean that as a pathologist, I ought to be able to simply count mitotic figures and to thereby predict the survival of cancer patients. And I knew that that was relevant to some extent, but it certainly wasn't all of the story, and it couldn't match Keratin-17 as a biomarker to predict survival. So we started to think about other avenues that we should explore. And this was based in part upon the recognition that Keratin-17 also encodes a chromatin remodeling domain. So we began to move beyond models depending on manipulation of Keratin-17 expression in cell culture to genetically manipulate Keratin-17 and then express it in these cells that could then be implanted orthotopically into various anatomic sites. And the primary focus of our lab is actually a focus on pancreatic cancer. So as you can see in the right-hand side, we're injecting Keratin-17 positive cells into the head of the pancreas. And following that, we can measure differences in the size of the tumors as detected by high-resolution ultrasound. But we can also look at how Keratin-17 expression impacts the survival of the animals. And you can see that in this experiment, the Keratin-17 positive tumor cells killed the animals much faster than the tumors that did not express Keratin-17. Furthermore, Keratin-17 positive cells were more likely to have areas of necrosis, which I know as a surgical pathologist, is one of the hallmarks of a biologically more aggressive form of cancer. And in addition, Keratin-17 positive tumors metastasized earlier, and hepatic and pulmonary metastases were more numerous. And finally, through immunophenotyping by flow cytometry, we found that there was an increase in myeloid-derived suppressor cells and a suppression of total T cells in tumor cells that express Keratin-17 versus those that do not. That observation has prompted us to try to look more carefully at how Keratin-17 might be actually impacting the inflammatory microenvironment. We're doing this through a number of techniques, including multiplexing immunohistochemistry, using bright field technology, where we can stain using different colored chromogens up to 7 different cell types simultaneously in a single histologic section. Although soon we will be moving to using bar-coded primary antibodies to take our multiplexing capacity up to a level of about 40 to 50 targets per section. So I'm not going to talk about the data here, but in general, you can see that we're able to separate out the teal CD4 positive helper T cells, the CD3s, the CD8s, the CD20s, based on their color. We convert these to whole slide digital images, and then have developed machine learning tools and artificial intelligence to be able to quantitate each of the different cell types and to enumerate the number of cells and their spatial relationships to the tumor cells, dependent upon whether the tumor cells do or do not express Keratin-17 or other biomarkers. So another thought about, back to the question of why is a Keratin-17 cancer so much more lethal than a Keratin-17 negative cancer? We question whether or not it might have any impact on chemoresistance. So panels A and B were derived from data mining of RNA-seq data in a database called ICGC. And the ICGC database has some similarities to the TCGA that many of you are probably much more familiar with, but it deals with an older, a cohort of patients collected at an earlier point in time, where, which included a time where pancreatic cancer patients sometimes were treated with gemcitabine as the sole chemotherapeutic agent. And what we saw here then was that we could separate patients as to whether or not they got gemcitabine. And in panel A, we saw that if the tumors didn't express Keratin-17, then gemcitabine worked. There was a survival benefit. But if the tumors had high levels of Keratin-17, then gemcitabine was completely ineffective, suggesting that gemcitabine, that Keratin-17 was driving chemoresistance to this particular chemotherapeutic agent. So then we decided to test this concept in cell culture, in this case using human-derived Miyapaka cells, as well as murine-derived KPC cells, where we, using a gain-of-function model, turned on Keratin-17 and compared it to cells treated with empty vector. And as you can see in panel I, in either the 2 different cell types, the EC50, or resistance to gemcitabine, was much greater in the cells that express Keratin-17. And we got a very similar result when we looked at 5FU, which is probably the most important component of FOLFIRINOX, which is currently a first-line agent for the treatment of pancreatic cancer. So we are continuing through a multi-pronged approach to try to identify different ways to target Keratin-17. Working in our animal models for validation, but also through data mining. We're using robot-assisted pharmacologic compound high-throughput screening in collaboration with investigators at the Scripps Research Institute. And through that have identified a candidate drug, podophyllitoxin, which actually synergizes with gemcitabine. And we're moving beyond that for expansion into ultra high throughput screening to identify additional candidate drugs that could be used to target Keratin-17 positive tumor. In addition, we are pursuing this type of an approach through virtual in silico high throughput screening. And finally, based upon recent tools that allow us to predict the tertiary structure of Keratin-17, even though it has not yet been crystallized. We've been able to identify small molecule inhibitors that are designed to block the interaction of specific functional domains, including the compound shown in the right-hand side of this slide that's designed to block the interaction between Keratin-17 and P27. And this agent is currently undergoing preclinical testing in our laboratory. So this slide here summarizes a review that one of the students wrote over the past year in the face of COVID, when she couldn't actually come in and generate bench-based research. But it's based upon work done in our laboratory and now many other laboratories that have shown that Keratin-17 impacts many different hallmarks of cancer, including not just sustained proliferative cell proliferation, but impacts on signaling, angiogenesis, resistance to apoptotic cell death. It impacts epithelial mesenchymal transformation and inflammation. And with regard to its ability to drive chemoresistance, we're looking at how Keratin-17 specifically is able to upregulate biosynthetic pathways that can explain why tumors that express Keratin-17 don't respond to pyrimidine analog agents. Okay, so thanks for sticking with me for the more of the basic mechanistic and discovery phase of the talk. Now I want to talk about some more practical applications, and I'm going to shift gears specifically to what I was invited by Paco to talk about, which is to talk about Keratin-17 and how we've developed it as a diagnostic biomarker, in this case for urothelial carcinoma. So why do we do this? As Paco mentioned, urothelial carcinoma is extremely common. It's the second most common cancer of the urinary system, with close to 18,000 individuals that die of this disease every year. This slide summarizes in cartoon form the different stages of progression of urothelial cancer. About 70% of these cases, when detected, are non-muscle invasive. About 25% are muscle invasive, and about 5% have already are metastasized at the time of diagnosis. Survival rate depends very much on at what stage the cancer can be detected. Almost everybody survives as long as the tumor is not extended beyond stage T1, but then the survival rates drop dramatically thereafter. Now, while these early stage tumors don't kill patients very often, they are still a very important clinical challenge to deal with, because a high proportion of them will recur after primary treatment. And a significant fraction, estimated at 10 to 20%, will actually go on to progress to more advanced stage cancers, even while under surveillance. So the diagnostic approach that we've all used in the practice of cytopathology is to collect samples which, in patients that are at higher risk for having an underlying cancer, may actually have gross hematuria, but also microscopic hematuria may raise some suspicion for an underlying malignancy. We look at the cells by urine cytology at papinicula stained images, and we can readily separate out squamous epithelial cells that are typically contaminants versus the morphology of urothelial cells. And when the morphologic features of the urothelial cells warrant a diagnosis of cancer, then the next step is cystoscopy and biopsy for biopsy confirmation. A problem with cytology, however, is sometimes, as a cytopathologist, I can't tell for sure if the case is positive or negative. Therefore, we use these diagnostic terms such as atypical or suspicious. When I say suspicious, it means I'm about 90% certain that they have cancer, but I don't want to say it with 100% certainty. If it's atypical, I really don't know, and I can hazard a guess, but the specificity for this diagnosis is not very high. And overall, while urine cytology, when we classify cases as positive or negative, is over 98% specific, it misses a lot of cases that don't have clear-cut cytologic features. So there's a need for a more sensitive diagnostic test for urothelial carcinoma. This challenge has been addressed over the past 3 years, especially through the deployment of the PARIS system for urinary cytology. The diagnostic categories are listed on the left. My concerns about the PARIS system is that while it's decreased the number of cases that get classified as atypical, it does not allow for the possibility of a diagnosis of negative for low-grade urothelial carcinoma or suspicious for low-grade urothelial carcinoma. So if I look at a slide and I'm thinking about low-grade urothelial carcinoma as a diagnostic possibility, that doesn't fit into the PARIS system. And what I'm left with is to either call it atypical without qualification or to call it negative. And even, again, if I call it negative, I'm not saying it doesn't have cancer. I'm saying the patient doesn't have low-grade or doesn't have high-grade cancer. So there are a bunch of FDA-approved urothelial cancer biomarkers that have been available for many years. We established, set up Eurovision at Colorado, probably 20 years ago. And it's about the best of the commercially available biomarkers. But as you look across the data for sensitivity and specificity, you can see that sensitivity for urine cytology is low, but it's got good specificity. Eurovision misses a lot, detects about 63% of cases. And the cases that it picks are the low-grade cases, because the low-grade cases are diploid tumors. While Eurovision does very good at the detection of high-grade tumors, so does urine cytology. These other biomarkers have relatively low sensitivity and low specificity. And the primary clinical attraction for the use of such markers is that while they may not be accurate, at least they give a result that's either positive or negative that helps the urologist to decide how they're going to manage their patients. But I think that the sensitivity and specificity should raise serious doubt as to whether or not we can depend upon those results to guide treatment decisions. So there's a need to find a biomarker that will work to detect any grade of cancer, both low grade and high grade. So to address that, we developed a novel, very sensitive and specific biomarker-based test to improve the diagnostic accuracy for urothelial carcinoma. The reason we thought about urothelial carcinoma and Keratin-17 is that through data mining and looking at RNA-seq data and other parameters, we were actually able to spot a number of different cancer types that seem to have relatively high levels of Keratin-17 across types. And for many of these, we've gone on to validate them as prognostic biomarkers. Going beyond cervical cancer, we've published now on head and neck cancer. Keratin-17 is specifically overexpressed and prognostic in triple-negative breast cancer. It's also true in non-small cell lung cancer. And we've done most of our work actually focusing on pancreatic cancer. But bladder cancer is actually different from many of the others because there is a more consistently overexpression versus a dichotomy of some cases being high and some cases low for Keratin-17. In general, almost all cases of bladder cancer have high Keratin-17, suggesting that Keratin 17 may be less important as a prognostic biomarker, but it might actually be a diagnostic biomarker in the context of that disease. So before we can test anything in a urine cytology sample, we have to understand what's going on at the histologic level. And that's the approach that I took when we first developed P16, and I reiterated that approach to say that before we start staining cytology specimens, we've got to look at to understand what's going on in the tissue. So for this pilot study, we took 100 cases, and these were specifically selected to provide a diverse spectrum of categories ranging from normal to non-papillary high-grade urothelial carcinoma. These were also all processed by routine immunohistochemistry. And when we started to look at the staining patterns, we found that in general, there was minimal staining of benign urothelial mucosa, but that across all grades of urothelial carcinoma, we were seeing Keratin 17 expressed in most cases. Importantly, however, if you look carefully at these images, you ought to appreciate that saying that every case is positive does not mean that every cell within every case is positive. So here we have a high-grade urothelial carcinoma, but it does have a fraction of tumor cells that are essentially Keratin 17 negative. But if we say, okay, we're going to define a positive test result as to whether or not there's some Keratin 17 somewhere within the tumor, then we get very high sensitivity and very high specificity for the presence of cancer or not. Again, looking at the bar graph on the lower left, this reflects what fraction of the tumor cells stain for Keratin 17. And what's important to see is that the fraction that stains in normal mucosa is extremely low. It's much higher across any grade of cancer, but still there's a large proportion of Keratin 17 negative tumor cells in most cases of urothelial carcinoma. So we have to understand that in order to be able to understand what would happen if we apply this to urine cytology. So the conclusions from the biopsy data is that Keratin 17 is detected in all types of cancer, both low-grade and high-grade of the bladder mucosa. This is in contrast to Eurovision, which would pick up high-grade but miss most of the low grades. We also found, although I didn't show you an example, that Keratin 17 also consistently detects pun lump, which is an acronym that stands for low-grade urothelial neoplasm of low malignant potential. These may be precursors or not of papillary low-grade urothelial carcinoma, but they have minimal risk for progression to cancer. Secondly, based upon the insight that we got by looking at Keratin 17 expression in the tissue, we decided that it made sense to now look at Keratin 17 as a candidate biomarker in urine cytology specimens. So we approached this through multiple steps. The first, again, re-emphasizing the diagnostic challenge, we've got problems with low sensitivity of urine cytology and non-specific diagnoses of atypia or suspicious that are difficult to take clinical action on. We arbitrarily initially decided that we were going to find a positive test result for Keratin 17 immunocytochemistry as any slide where we found at least 5 urothelial cells that stained for Keratin 17. We didn't know if that was the right threshold. This was selected arbitrarily, but then we set out to see if that worked or not. Secondly, we want to know, could Keratin 17 help resolve a diagnosis in cases that were called atypical, where the pathologist couldn't call the case either definitively positive or negative. And third, we want to know, could there be a role for Keratin 17 immunocytochemistry, either for the initial diagnosis of urothelial carcinoma in patients that were under consideration because they had blood in the urine, Or alternatively, or in addition, could it be used to help monitor patients that had already been treated for bladder cancer, and we wanted to see if the disease was going to recur? So for this pilot study, we took about 70 cases. These were not randomly selected. We wanted specifically to, within a certain time point, find as many cases as we could within some specific diagnostic categories. I especially wanted to focus in on cases that were suspicious or had some degree of atypia. I also wanted to see what was going to happen if there was acute inflammation or reactive changes, since I didn't know for sure whether or not that might cause essentially false positive Keratin-17 test result. We performed staining on the slides using thin prep and techniques for staining that were very similar to what we had performed on the tissue biopsies. And what we saw was that in, for example, panel A, in a patient that did not have bladder cancer, there was minimal or no detection of Keratin-17. In panel C, you can see a case with a few Keratin-17 positive urothelial cells. Panel D shows many more, and panel B kind of highlights the difference between a Keratin-17 positive urothelial cell versus a squamous epithelial cell, which is a contaminant, and in this case has minimal staining. We defined a test as positive if we found any Keratin-17 positive urothelial cells. In fact, we had no cases in the series where there was less than 5. But for the structure of the study, we said if there's even one, we'll call it positive, and we call it negative if there's no cells at all. So in this pilot study, this data on sensitivity and specificity doesn't really mean anything, because these are all patients where we already knew what the diagnosis was. It's not representative of what would normally come into the lab, but we had picked out cases to try to test different diagnostic categories. Having said that, it looked intriguing that Keratin-17 did better than urine cytology, both in terms of sensitivity and specificity. The high sensitivity reflected by urine cytology here, however, reflects the fact that these were pre-selected cases based upon a pretty definitive urine cytologic diagnosis. So having shown that we can make it work on urine cytology slides, we then decided, okay, the next step is to try to test this out in consecutively collected samples. So we started to think about how to include a broader discovery cohort and then a separate independent validation cohort to test this idea. So for this study, we collected 179 cases that were submitted consecutively to our cytology laboratory here at Stony Brook. And we divided those into 2 groups, which we named discovery cohort and validation cohort. And these 2 groups were reasonably well developed by a number of different patient and tumor characteristics. About half of the discovery cohort had hematuria as the reason that the sample was submitted to the laboratory. It was a little bit lower than that for the validation cohort. And a high proportion of these cases that we get in our laboratory are for patients that have already been diagnosed and are being treated for urothelial carcinoma. In the study, in the discovery cohort, we found a sensitivity of 97%, which was extremely high, not quite as high in the validation cohort, and similarly, specificity range was at 86% and 92% in the 2 different cohorts. So this was very encouraging. But the limitations were that we only could look at the biopsy confirmation in the cases that happened to have a biopsy, which represented between 26 and 38% of the cases. Also important to understand, we defined the positive test result based upon what the biopsy showed, either of a biopsy collected at about the same time that the urine specimen was collected, or if a diagnosis of cancer was made within 12 months prior to or subsequent to the collection of the cytology sample. So this doesn't tell us necessarily what the sensitivity is for what would have happened if a biopsy had been collected at exactly the same time of exactly the right spot in the bladder. But it is our best estimate of a final clinical pathologic diagnosis as to whether or not the patient has cancer or not. Next question is, could Keratin-17 be useful in cases where the cytopathologist can't make up their mind and they resort to having to sign the case out as atypical rather than as positive or negative? And when we looked at this and then related to that to whether or not the patient later turned out to have cancer, we found that Keratin-17 immunocytochemistry had a very high sensitivity and specificity to resolve those cases of cytologic atypia. Finally, here we looked at cases where the reason for referral for testing was blood in the urine. And here it was shocking to see that while there are only 11 cases that had biopsy confirmed cancer, cytology missed all of them. But Keratin-17 picked up 100% of those cases. And in addition, it picked up several other cases that got a biopsy subsequent to the positive urine or subsequent to the urine cytology test result. Here, instead of looking at patients with hematuria, we're looking at patients that are already known to have had bladder cancer at some point and they've been treated. The question is, has the cancer come back or not? And with this cohort, Keratin-17 immunocytochemistry had a very high sensitivity again. As expected, cytology didn't work very well, but the specificity for either cytology or for Keratin-17 was quite high. And then the final question was, knowing that Eurovision doesn't work for low-grade papillary urothelial carcinoma, is Keratin-17 any different? Is this just a marker of the high-grade tumors, or does it pick up all cases independent of grade? And this slide summarizes data to show that it picks up both low-grade and high-grade cases. And then the next question is, are these results just what Shroyer can achieve sitting in my office here? Or is it possible that this type of data could be replicated by other pathologists? So in this case, we took a series of cases that had been identified as Keratin-17 negative and others that were considered as Keratin-17 positive. We had two different cytopathologists score these independently of each other to figure out how often do they come up with the same test result. And in doing that, the inter-observer agreement was imperfect. It was 88%. We had a kappa value of 72%. So there may still be room for improvement in this assay. It does suggest that for this assay to be clinically deployed, we have to be very, very careful to make sure that the cytopathologists are very well trained in how to read these slides. This is not like a dipstick test where you can turn it over and ask people to read the case as positive or negative based on a clear, easy to read test result. Instead, it requires that a cytopathologist screen the entire slide optimally with the help of a cytotech and identify if there are cells there, are they urothelial cells? And if they're stained, is it classified as strong or not strong? And only then with that type of training can they be expected to approximate the diagnostic accuracy that we were able to achieve? So that's a challenge, but it's not one that can't be overcome. So in conclusions, I've shown you evidence from urothelial cell urothelial cell cases that detection of staining in over 5 cells defines a positive test result, that there is some substantial inter-observer reliability for the diagnosis between pathologists. This biomarker is both sensitive and specific, both for the initial screening of patients with hematuria and for patients with cytologically atypical urine specimens, and to detect recurrent urothelial carcinoma, including both low-grade and high-grade tumors. And to wrap this up with my last slide, I've shown you evidence this afternoon that Keratin-17 can be used as a diagnostic biomarker for urothelial carcinoma, and in other cancer types, it can also be prognostic for survival and even predictive to help select what type of therapeutic intervention is most likely to be effective across a diverse range of cancer types. So Keratin-17 drives tumor aggression, it confers chemo resistance, and therefore may serve as a novel therapeutic target. Keratin-17 immunocytochemistry can be regarded as a non-invasive test because it doesn't require an additional biopsy. It utilizes remnant urine samples that are routinely submitted to a cytology lab for diagnosis, and even then is highly sensitive and specific for urothelial carcinoma. The data we have right now has provided the foundation for ongoing prospective clinical trials to show how Keratin-17 immunocytochemistry might ultimately even be used to replace urine cytology for bladder cancer screening and for surveillance. And this work has served as the foundation for an NIH-registered clinical trial of Keratin-17 that's been completed now in the United Kingdom, and an ongoing FDA clinical trial that has been established here in the US. For my last slide, I want to acknowledge that this has been this work's been conducted by a wide range of investigators. Most importantly, Luisa Escobar Hoyos, who was a graduate student at the beginning of this journey, and now is an assistant professor at Yale, but still stays in close contact with our laboratory. Here's Luisa in the green jacket on the right. Shruti Babu here got her PhD in my laboratory. And when she completed her PhD, I was fortunate enough to be able to recruit her to our residency program. She's now a second-year resident. Leanne is one of our really excellent technicians within the laboratory. Michelle Wu was an undergraduate student. She's now a graduate student at MIT. I'm sorry, she was a high school student. She's now an undergraduate student at MIT. Mariana, postdoc, is now in Brazil. Ryan Korolarski, he was an undergraduate student who is now an MD PhD student at Yale. And Chun Hao, I really need to point him out because he's the guy that's driven much of the mechanistic studies to understand how Keratin-17 drives chemo resistance. And Chun Hao is going to get his PhD next year in the molecular and cellular biology program here at Stony Brook. So with that, but thanks everyone for your attention. It's been a real privilege for me to be able to share these updates.